So this is our part 2 audio on anemia, and we're now specifically looking at thrombocytopenia. So by definition, thrombocytopenia is when our platelets are less than 150,000. And then we'll kind of talk about how that may look in the patient. So if your patient's platelets are at least 50,000 or greater, in the patient you may not see any bleeding, and you might not see any petechiae, right? So 50,000 or greater, usually no bleeding and no petechiae going on. When your platelets drop to less than 20,000, you're going to see petechiae, and I know I'm not saying that right. That's going to show up. You may see things like nasal, gingival bleeding, excessive menstrual bleeding, and excessive bleeding after surgery or dental extractions. So this is just how this is going to show up in the patient. If your platelets are less than 5,000, that's when you're going to be seeing things like fatal central nervous system or GI bleeding happening. So that keyword there being fatal, right? So there's a whole bunch of different things that can cause thrombocytopenia, right? So maybe there's a decreased production in the bone marrow, right? So maybe there's an increased destruction of platelets, or maybe there's an increased consumption of platelets for clot formation. You don't care what it is, but there's a whole bunch of different things that can cause thrombocytopenia. So decreased production in bone marrow production, increased destruction of platelets, increased consumption of platelets for clot formation. So any of those things can be an issue. If your patient is on medications, in particular if they're on things like aspirin, you already know that there's an increased risk of bleeding. So even when their platelet level is, let's say, normal, or maybe it's a little bit less than what it should be, you are still monitoring your patient very, very closely just because they're on the aspirin, right? You just want to make sure that you're following their labs very, very closely, because you already know that they're not aspirin, that they can end up going into trouble. All right. So like literally, guys, thrombocytopenia is just where I'm talking about it just because, but really this should not even be a topic separately for you guys. So what might you see in the patient? So things like weakness, fainting, dizziness, tachycardia, difficulty in arousing. So once again, it depends on the amount of platelets that you have. So that's why we went through the different manifestations depending on how much platelet levels you have, right? So this patient is not going to be the one that's, let's say, has 140,000 of platelets. This is probably going to be the one that has the decreased levels that we mentioned earlier, which was what, like less than 5,000 or something crazy like that, right? So definitely they have cerebral hemorrhaging going on, and it's difficult to arouse them. So you're paying attention to the manifestations, but you're tying them to the levels of platelets as well. Things like abdominal pain due to GI bleed and abdominal spasms, things like hypotension due to internal bleed or hypovolemia. So you're monitoring all of that closely. Your collaborative interventions. So what are you going to do? Control the problem. Whatever the problem is, you're going to control it. If it's bleeding, we're going to control the bleeding. So you're looking to see whether or not there's blood in the stools, in the vomit, or the urine. You're reporting that to the provider. You're looking to see if there's any difficulty talking, sudden weakness of extremity, or feeling confused. You're reporting all of that to the provider. You are treating the etiology. So I've given you, on that first slide, we talked about some of the things that could be the problem, right? The etiology. So then you are going to treat whatever that etiology is. So you're avoiding IM injections. If they have to get injections, you're giving sub-Q injections with the small gauge needles, and you're giving a direct pressure after the procedure. If a woman is menstruating, you want to make sure that they're counting their sanitary napkins, because you want to see whether or not they have the numbers of sanitary napkins increases, whether they're bleeding more, right? So now, because if there's an increased frequency with them, having more sanitary napkins and more bleeding, then that's a problem. Using a soft bristle toothbrush, using electric razors, not razor blades to shave, do not strain when having bowel movements, using stew softeners, avoiding NSAIDs. All of that goes without saying, right? So you're monitoring your patient very, 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 very closely. Then we get into disseminated intravascular coagulation, also known as DIC. And you should have come across DIC somewhere along your tenure at BMCC, maybe a little bit in 313 or maybe even in maternity, I'm thinking. Anyway, so these are all the potential conditions that can predispose you to having disseminated intravascular coagulation. So you're going to just look at these very loosely. And we are going to focus on, okay, why does a patient have DIC, right? So key word is the natural anticoagulant pathways are altered. There's inflammation and coagulation happening. There's abnormal and accelerated activation of the clotting, and then there's a paradoxical effect. So keyword is abnormal and accelerated activation of clotting. And unfortunately, what happens is you have a paradoxical effect. So normally you would think, okay, I have clotting, so therefore I'm not going to bleed. But that is not what happens. Unfortunately, it's a weird, funky effect that happens. That word paradoxical means weird, bizarre, strange, or unexpected. Instead, what happens is now you get excessive clotting and you get excessive bleeding. So there's profuse bleeding because of decreased clotting factors and decreased platelets, because some of the clotting factors end up being used up, and the thing is you have to treat the underlying cause. So whatever the cause is as to why you have this inflammation and basically coagulation happening, that is what you're going to target. I've added another slide specifically from your book just to kind of unpack some of this more. So keyword is normal hemostatic mechanisms are altered, inflammatory responses generated by the underlying disease. You get a process of inflammation and coagulation that's going on. Your natural anticoagulant pathways within the body are impaired. That's what's going on. The fibrinolytic system is suppressed. So now you're getting a massive amount of tiny clot formation in the microcirculation. Initially, the coagulation time is normal. However, as the platelets and clotting factors form, microthrombi, coagulation fails. So at some point where you're getting clot formation, it's fine, but then later on, things are impaired, and there's no better way for me to explain this to you. Just know that it's a funky process going on. The coagulation is failing, and you're ending up with a paradoxical effect that happens, and you're getting excessive clotting and bleeding. What are you going to see in terms of your clinical manifestations? They will be reflected in the compromised organ failure, function, or failure. So the manifestations you're going to see are going to be because of the result of excessive clot formation. So you're going to be seeing things like ischemia to all or part of the organs. The excessive clotting will trigger the fibrinolytic system to release fibrin, which are potent anticoagulants, right? And then that's going to lead to more bleeding. So all of this is funky, it's bizarre, it doesn't make any sense. And so just know that the end result is you're going to get low platelets, fibrinogen levels are decreased, you're getting prolonged PT and APTT, and thrombin time. Like, those are the main things that I would highlight. So funky situation going on. It does not make sense is the best way that I can say that to you. You do have a chart in your book. For some weird reason here, it doesn't look that great. But it's in your book, so you can just look at that as well. And once again, you're not overthinking. Just know that at the end of the day, I'm getting excessive bleeding, excessive clotting that is happening. The main thing is what you want to focus on is that you're treating whatever is causing it. So remember, there was that chart with all the potential things that can lead to things like inflammation. So whatever the condition is, whether it's sepsis, whatever it is, you want to diagnose that it's DIC as quickly as possible. You want to stabilize the patient. You want to treat the underlying cause while providing necessary blood products as quickly as possible. The mortality rate is very, very high. especially if the patient has severe DIC with ischemic thrombosis, frank hemorrhaging, and multiple organ dysfunction syndrome. So you can really die from this if it's not treated as quickly as possible. So assess thoroughly and frequently for signs of symptoms of thrombi and bleeding, and monitor for any progression of these signs. You're looking at your lab values. You're looking to see whether or not they're being monitored, they're being supported with the respiratory functioning. So for sure they're going to be on a ventilator as quickly as possible. You're looking for any central nervous system involvement as quickly as possible, and you're assessing the level of consciousness. All right, so that was it with the DIC. And literally it's just giving back blood and treating whatever the underlying cause is. And then we get into neutropenia, and once again this is something that you know already, but now we're kind of just describing it a little bit more for you, so that it can make more sense. All right, so when we look at neutropenia specifically, so now we're kind of breaking it down a little bit further. So by definition, it's a decreased amount of neutrophils, and it's a neutrophil count of less than 2,000. So that is pretty bad. So there are different categories of neutropenia. Well, not categories, but like, well, if somebody's neutropenic, how do you know whether or not they're more likely to get an infection, right? So there's this nice funky little thing that we call an absolute neutrophil count. If that count is less than 1,000, then we know that the patient's risk of infection is pretty significant, right? If the ANC is less than 500, then we know that the risk is high. And if we know that the ANC is less than 100, then we know for a fact that infection is certain. So now we're not just looking at, because normally we talk about WBCs, and then we're happy if like our WBCs is 5,000 or greater. Well, now in order for us to specifically know whether or not a patient is going to have an infection, we look at the neutrophils. So the neutrophils, specifically when we're talking about the absolute neutrophil count, that gives us the real number of WBCs that are neutrophils. So it gives us the portion of the WBCs that are neutrophils, and we care about that number because that's going to let us know whether or not a patient has an infection or they're at risk for an infection, right? So they have a whole little complex way of calculating this. They look at the WBCs, and then they look at the amount of neutrophils, and then come up with some differential count. You don't need to know that. You just need to know that when we're talking about neutropenia now, the neutrophils count. They are the ones that we are looking at. All right, so we're worried already if our neutrophil count is less than 2,000, right? So in order for it to qualify as neutropenia, we know that our neutrophil count is less than 2,000. Well, are they going to get an infection, or are they not going to get an infection? Well, if our ANC now is less than 100, for a fact they have that infection. If it's less than 500, their risk is very high for an infection. If it's less than 1,000, the risk of infection is significant. So there are different stages. So this is, I mean, just for you to know, especially if you're like on a cancer unit, where the patients are maybe neutropenic, right, or neutropenic precautions. So this is why all of this becomes like a big deal. So then you look at all the different things that can make somebody neutropenic, right? So use of chemotherapy, immunosuppressive therapy, all of those things are common causes of neutropenia. Your sweet spot in terms of the absolute neutrophil count, so different books would give you different ranges, but if you had to pick a number, you would want the neutrophils themselves to be anywhere from 2,500 to about 6,000. So 2,500 to about 6,000. Then you're good. Like you have a buffer, you're not going to be getting infections, and you're happy. And once again, you remember that once the neutrophils are 2,000 or less, then you start getting worried. And then there are different degrees of how worried you get. in terms of whether or not your patient is going to get an infection. All right, so your clinical manifestations. So if there are neutropenic, right, it's kind of hard for them to even get the normal mechanisms of showing the signs and symptoms of being sick in some cases, right? So they're not going to be exhibiting classic signs and symptoms of infection. A fever or temperature is the most common indicator of an infection, but it is not always present, once again, especially if the patient is taking steroids. So that's why all of this becomes really, really complicated. So treatment of neutropenia varies depending on the cause. If it's medication induced, then you're going to stop that medication if possible. So if possible being the key word. If the neutropenia is accompanied by temperature, the patient is considered to have an infection and usually is admitted to the hospital. So the fact that you have the temperature, the fact that they've looked at your labs, then they're going to just say, you know what, there's an infection cooking here. So they're going to do cultures of your blood, urine, sputum, chest x-rays, all of that is supportive data. They're going to start giving you broad spectrum antibiotics initially until they know exactly what the infection is. Let's see, your clinical manifestations. So once you are neutropenic, right, you're basically at risk for getting everything. So we already mentioned the fact that now you're predisposed to infections. So it's both opportunistic organisms and your normal flora that normally would not be an issue. All of that now becomes a problem for you. Because your phagocytic mechanisms are impaired. So you're at risk for opportunistic organisms and even just your normal things in your body because your normal mechanisms are impaired. You may not have the normal signs of inflammation to even let you know that you have an infection. Pus may not even be present, like all the usual things that would happen to fight off your infection. So remember, you normally would have the inflammatory response, all those weird things going on. Those may not even necessarily be going on. So anytime a patient has a low-grade temperature, that's a great significance because your patient may actually be going into septic shock. But remember, once again, you're looking at all your labs and specifically you're paying attention to our ANC to see where it's at, and all of that is going to be helpful in terms of determining whether or not your patient is in trouble, right? So you're checking your temperatures at shorter intervals, and once again, this is going to vary at each institution, so you just want to watch that very, very closely. So maybe you're going to see things like a sore throat, dysphagia, ulcers in the pharyngeal and mucosal mucosa, diarrhea, rectal tenderness, vaginal itching, shortness of breath, a non-productive cough. All of these are possible. In terms of your nursing management, guys, when it comes to neutropenia, I mean, there's really not much for me to say. The nurse plays a crucial role. That's why this slide is here. Like, you have to assess the severity of neutropenia and in preventing and managing complications, which most often include infections. So nurses in all settings have a crucial role in assessing the severity of neutropenia and in preventing and managing complications, which most often includes infections. So that's a big deal. So collaborative management for sure. You're determining the etiology. You're identifying the offending organisms. You're giving the administration of broad spectrum antibiotics as quickly as possible. You're giving any blood products early on if needed. That's going to be helpful to basically help your patient do better. So maybe you're giving things like Epogen, especially if they're cancer patients, because that will help with red blood cell proliferation. So Epogen, E-P-O-G-E-N, or Procrit is the other word, P-R-O-C-R-I-T, right? So those are things that help with red blood cell production. Those may be beneficial in some patients to basically boost up your blood cells. So strict adherence to infection control, especially hand washing, instructing the patient to apply moisturizer to dry skin to prevent skin breakdown, because then that becomes a reservoir or a medium for possible infection, not allowing plants or live flowers in the patient's rooms. I mean, that is literally all you're doing for neutropenia, right? So some of this you're already familiar with, but it becomes even more important when we start talking especially about cancer in a little while.